Good afternoon, everybody. Welcome to today's event. I'm Dr. Pratik Kande, Chairperson for the Amongst Endocrinology Committee. A warm welcome to all the faculty for today's event, as well as the audience who's logged in from across the country. Today's theme is infertility, and we are going to be discussing evidence-based best practices in IUI. And to carry out this case-based discussion, we have a galaxy of stalwarts who practice both basic infertility as well as IVF from across the country. And without further ado, we will start the scientific proceedings. But I would first like to express my gratitude to the amongst office bearers. Our beloved President, Dr. Nandita Palshetkar, Madam is the current President of AMOX. She has served as the President of the Mumbai Society, IAG, and Foxley in the past. Currently, the Vice President of ISAR. Thank you, ma'am, for your blessings and your guidance always. Next slide, please. I would also like to express my gratitude to Dr. Arun Nayak. Sir is the Secretary of AMOX, served as the President of Mumbai Society in the past, a distinguished academician and a fantastic vaginal surgeon. Thank you so much for your blessings and your guidance for all our academic endeavors. At this stage, I usually like to express my gratitude to the ICOG office bearers, the chairperson, Dr. Uday Thanawala, and the secretary of ICOG, Dr. Ashok Kumar, for granting us the ICOG credit points for all our events which we have conducted online, including today's event, which is accredited with one ICOG credit point. Next slide, please. So today's panel is on infertility management and specifically the evidence-based best practices for IUI and to debate the various issues regarding intrauterine insemination. We have a galaxy of stalwarts from all across the country. To begin with, the expert for the panel is none other than Dr. Milind Shah. Sir is the president of ISOPA 2016-18. He is also served as the vice president of Foxley way back in 2011, joint treasurer of ISPAT 2017-19, deputy secretary general of INSAG, which is the Indian Society of Aesthetic and Regenerative Gynecologists, ex-chairperson for the Rural Obstetrics Committee of Foxley a long time ago, managing committee member of several national organizations, including IAG, ISAR, and IFUMB. He's a peer reviewer for the journal and also a fellow of ICOG and IAG. Welcome, sir, and we look forward to your expert inputs on the various different clinical cases and the scenarios which we are going to discuss today. Next slide, please. We also have with us Dr. Sushma Tomar. Madam is a senior OBGYN and a practitioner from Ulasnagar, which is a place very close to where I used to practice a long time ago. She has a diploma in advanced endoscopic surgery from Germany, also a fellowship in IVF from Belgium. She's also had a diploma in medical legal issues, diploma in psychology, cosmetic and aesthetics from different institutions. As you can see, she is a multifaceted personality and she's from the older generation like me, where after doing a lot of obstetrics and gynecology, staying up sleepless nights for several years or decades together, then we graduated into various different specialties, including infertility. Madam has received the Women Achiever Award from the Ulhasnagar Medical Corporation in 2006. Also received the Dhanvantri Award by the NIMA Association in 2008, Bharat Jyoti Award in 2013 for excellence in her work. And of course, her specialty interests include endoscopy and infertility. Welcome, ma'am. Next slide, please. We have with us Dr. Deepak Goenka, sir. Is well known to the infertility audience. He is the director of the Institute of Human Reproduction in Guwahati, has extensive training in ultrasound, laparoscopy, ART, and genetics at various institutions in India as well as abroad, including Singapore, Australia, UK, and USA. He's performing IVF since the last 24 years, does more than 200 endoscopic procedures a year, more than 20,000 IVF cycles so far, and personally, he's trained more than 500 specialists, in ART, specifically Iui, IVF. He also has a one-year fellowship course in reproductive medicine. Thank you so much, sir, for joining us, and we welcome your ideas and your inputs for today's panel. Next slide, please. We also have with us Dr. Rekha Rajendra Kumar. Madam is somebody who is a very distinguished infertility specialist practicing in Bangalore. She was a member of my committee when I was chair for the Oxy Endocrinology Committee. She's a practicing gynecologist for the past 30 years, 11 awards and 3 felicitations, including 3 state awards in Karnataka. She's the honorary secretary for BSOG, the Bangalore Society 2020 to 2021, South Zone coordinator for the Fox Infertility Committee, chairperson for the Infertility and ART Committee of Kasoga from 2020 to 2022, several publications to her credit, and she's somebody who is well known in academic circles as well. Thank you, ma'am, for joining us. Next slide, please. Dr. Kalyani Shrimali is a senior consultant from Nova Fertility in Indore, and she's trained extensively both in India as well as abroad. We present apologies on her behalf. She is unwell and she's had to excuse herself from the panel at the last minute. And she said she will try and log on as and when possible, but we present apologies on her behalf if that is not going to be possible. Next slide, please. We also have with us Dr. Sheetal Savanka. She has a diploma in reproductive medicine from Germany, has a master's in reproductive medicine from UK, also done a fellowship in ART. Currently, she is the medical director for Morpheus in Mumbai, associate vice president of fertility and gynecology services for Morpheus IVF, a very important council member for the Mumbai OBGYN Society, and she has several awards from the Mumbai Society to her credit. Thank you so much, ma'am, for joining us. And I see you are traveling, so thank you very much for joining us in spite of being on the road. We look forward to hearing from you. We also have Dr. Anurekha with us. She practices in the city of Salem, which is in Tamil Nadu. She is an alumnus of AIMS, CNC Vellore, JIPMOR, and CBNCH. She's an active member of Proxy. She was a member of my endocrinology committee when I was Proxy chairperson. She is an assistant professor currently at the Medical College in Salem, and she is also an ART and IVF consultant. Numerous awards to her credit, including the Kamini Rao Yuva Foxy Orator for the South Zone 2019, Michela Research Award from Foxy in 2009, Best Paper Presentation at Iui Cycle in 2016. She has more than 10 years of teaching experience and several publications to her credit. Lovely to have you with us, ma'am. Thank you so much for joining us. Next slide, please. And I think last but not least, Dr. Rima Sarkar is a consultant IVF specialist and obstetrician at Indira IVF in Islamabad, and now recently I think she's moved to Dehradun. She's an ex-associate professor from the Government Medical College of Faridkot. Several publications to her credit, and she's well known in ART circles as well. Thank you all of you for joining us. We are going to have a discussion which is centered mainly around intrauterine insemination and infertility, and hopefully this is something which will be practical, it's going to be evidence based, and somehow we'll try and amalgamate both the best practices as governed by various different guidelines, as well as what we actually do in clinical practice. We'll go through everybody one by one, and my apologies if I miss out anyone. Please feel free to raise your hands in case you wish to contribute on the specific cases. So I've spoken on for too long now. Let's go without any further ado to the first case. This is a lady who's 36 years old. She's married since 2 years, so that's obviously a late marriage. She's trying to conceive since 1 year. Regular cycles, but husband is not at home. He requires extensive travel. What investigations would we like to advise this couple? Obviously, at the age of 36, we need to speed things up, and we need to rule out several issues which are becoming more and more commonplace now in modern practice. Can we start with Dr. Tomar, ma'am? You must be seeing a lot of such couples, ma'am, which is different from when you started practice 30 years ago. Please unmute yourself. Please go
ahead. Thanks, Pratik. So, can you listen to me?
Yes, ma'am, we can hear you loud and
clear. Okay. So, regarding, because looking on her age 36, we are already running late, and she has tried naturally from 1 year. So now, because her husband is traveling quite a lot, so we are not sure whether they are having their planned contact on the ovulation time or no. So first, we will just work out for both couple. Day 2, we do all the hormonal profile to the wife. And on day 10, we do the HSG. Primary baseline, we do to everyone these tests whenever they are coming after 1 year of plant contact. On 10th day, we do the HSC and follicular study to just find out everything is normal from the female side or no. On the husband side, we will do the semen examination and routine blood test. Suppose all the things are coming normal, and because of his profession, husband profession, he is not able to have the plant contact on the ovulation time, then we will give the option to them. We are running late now, so we should try the IUI. So we will ask them to preserve the semen in our semen, all the IVF center, they are having the facility to preserve the semen. And we have to try for the IUI at least 3 cycles. So that's
So I
the
think
first.
Madam has raised several important issues here. Number one is the issue that at the age of 36, we don't want to waste any time. Number two, we need to rule out certain hormonal issues which can be commonplace in this particular age group. Number three, because the partner himself is not around, probably he's not around the time of ovulation, then the facility of semen freezing is something that we need to look into, which not everybody may have. If you are running an IVF center or you offer advanced fertility treatment, obviously it's going to be available at your center. But not everybody practices advanced infertility treatment. They may not have such facilities, and therefore, such a couple needs to be offered semen freezing as one of the important methodologies for treatment, which can be taken care of and which will help to increase their success.
Dr.
I see
Pratik,
Dr.
your
Deepak Goenka
voice
wants
is
to contribute. Yes, sir, please go ahead.
your voice is not very clear, and some hissing
All right.
sound is also coming whenever you are speaking.
All right.
Some breathing sound
Probably
is also coming.
yeah, it's probably because of the fan in the background, sir. Apologies. So, can we have somebody else comment on this issue? And I would like to invite Dr. Rekha to speak regarding this particular case. Can you contribute something besides what has already been said?
Yeah, and coming to the other than what Dr. Tomar madam told, I would like to definitely she's a candidate for intrauterine insemination, not more than 3 cycles because she's running out of time, 36 years. But when I am planning IUI for her, then I think I should investigate other than the routine investigations, the tubal status and the male factor I should know, and make sure that everything is fine. And then she has to proceed with controlled ovarian stimulation with IUI for next 3 cycles. Coming to the counseling part, I'll tell her that both of you are running out of time. Probably even husband is around 36 years or little more than that age, so she cannot try more than 3 cycles of IUI, and the fertility will fall less than more than age 30, then after 35 and after 40, that graph I will tell her that it will fall. So I will prepare her for IUI of only 3 cycles. I will tell her that you cannot sit at home and try for pregnancy on your own. Also, I will tell her that more than 3 cycles of IUI, the success rate falls. And after 3 IUI, if you have not conceived, you have to make up your mind for IVF. This is what will be main part of counseling to her from my side. And definitely the IUI may have some kind of success in her instead of trying naturally, because I'm answering your last question.
Can we have Dr. Anurekha contribute something to the discussion? Ma'am, can you tell us what endocrine issues or hormonal problems we can encounter in this couple at this age?
So I would like to have her AMH done. She's already 36 years old.
Yes,
So can you hear me?
People are talking.
Yeah, I would like to have her AMH done because she is already 36 years old. Before planning for IUI or direct ERT, HC, I think it will help me. And also look on the antral follicle count, preferably on day 3 to day 7 of the cycle. Provided if the things are normal and if there is a tubal patency documented with her, then I'll go for an IUI. Otherwise, direct ART or HC will be an option. And one another thing, because Madam has already rightly mentioned she's 36 years, so she has to be counseled for chromosomal anomaly and prenatal genetic tests and all beforehand. So.
Dr. Deepak Goenka was trying to say something. Yes, sir.
No,
Please go ahead.
actually, I was apologizing everyone.
Yes, sir.
There was an emergency, as I told you earlier also, patient has just
Yes, sir.
come.
No problem. No
Hmm?
worries, sir. If
I'm so
possible, you
sorry.
can rejoin it. No problem, sir. That's fine,
Let me
sir.
see how
No
fast I
worries.
can do that.
No
Right.
worries, sir. That's fine. So let's hear from Dr. Sheetal Savantar. Madam is traveling, so we don't know how good her internet is. I wanted to ask her, do you think that we should directly jump to IUI as a modality of treatment for this particular patient?
Yes.
Okay, I don't see her. Probably she's dropped out because of the internet.
Hello,
Anyone else can take that? Yeah, go
Pratiksha,
ahead.
I'm there on the line. Yeah. So basically, I think it depends on how fast the patient wants to conceive. We have to give the choice to the patient as to when and how soon the patient wants to conceive because she's already 36. So once the patient crosses 35, if the patient, we have to give them an option that the chances of conception with an IUI cycle is just 12 to 15%. Whereas if she goes ahead with an ICSI, provided obviously, as people have said that we have to do her AMH, we have to do her antral follicular count. Obviously, based on that, we have to tell her the success rate with an IUI cycle, the chances of conception with an IUI cycle, with each IUI cycle is only 12 to 15%. Whereas vis-a-vis with an IVF cycle or an ICSI cycle, it is somewhere around 30 to 35%. So we have to tell them because your husband is traveling, these are the success rates which are there. And we have to explain that to the patient and tell them that because he's traveling, these are the best options that we have. Again, with a frozen semen sample, the chances of IUI also go down. So all these options we have to tell the patient and then give her a choice what she wants. Because with a frozen semen sample, ICSI success rate is not going to vary so much. So
I think
if the
that's a good
patient,
perspective to have, that we need to always prepare the patient mentally regarding the couple specific, each specific and condition specific success rates and what success rates we can actually offer them. Since we are talking about success rates anyway, can Dr. Sheetan tell me what is the average success rate for an IUI cycle
that
in
is what, so
general?
12, yes, so it is 12 to 15% with each cycle. And as the success, each cycle, like the cumulative pregnancy rate goes down with each IUI cycle. So 1 to 2 IUI cycle after the first cycle, it goes down only. So 1 to 2 IUI cycles are good enough with the age of 36. And if it doesn't work out, then it is best to switch over to IVF depending on the AMH and the AFC. That is what I feel.
All right. So I think most of the panelists are more or less in agreement that this particular clinical scenario, we don't take things for granted. We don't tell patients go back and keep trying. We need to investigate and rule out certain hormonal problems which can coexist at this stage, notably the issue of impaired ovarian reserve and other hormonal pathologies, especially if the woman's period or the cycle is irregular. We also need to be able to offer semen freezing as one of the options to this couple. And finally, last but not least, IUI will increase the success rate for this couple, especially when they are not having relations at that particular time of the month. Anything that you do, whether it's ICI or IUI, is going to increase the success rate. But using a frozen semen sample sometimes can compromise the success rate, and that has to be counseled well in advance. Anything else anyone would like to contribute, please feel free to go ahead. I see
Yes.
Dr. Nilincha sir is still traveling, otherwise we could have had his expert opinions as well. Please go ahead.
Yes, Pratik, the one more thing when we are just talking the on first visit, we have to tell the complication for the pregnancy, what abnormal baby can have, or we have to tell them the complication of the delivery and pregnancy also, because that counseling is very important. Because we have to investigate all the things for the Down syndrome, for the abnormal baby, for the diabetes, everything. So they should not think of it will be so simple. Success rate also we have to tell them as soon as the age advanced, the success is coming down. So everything should be counseled on the first visit only. We have to offer everything. What can be the problem in this age group for you and baby before pregnancy? Starting folic acid. Why we are starting the folic acid? So baby should have the less chances of abnormalities, everything should be counseled very properly on the first visit. And always prefer when the couple is there. They should not think of ki, my husband is not knowing this thing. I have come alone. So first counseling, I always prefer that couple should be there. So what I am talking to him, even after writing on the paper, at least couple should know the what can be the possibility.
Thank you, ma'am. I think
Yeah, Pratik, can I have a comment on this?
yes, sir. Please go ahead, sir. We were
Yeah,
waiting
yeah,
for you.
good. Yeah, I understand. Actually, still I'm in car, but I can definitely put my inputs. Yes, this particular case has a two implications: the social indication as well as the medical indication, because her age is more. So I think we'll have to be very, you can say, non-directive, non-judgmental counseling, which is going to play a major role in this particular case. Because social indication, yes, we can actually think about various other the social actually sort of solutions for that. But medically, as we know that her age is 36, and as now just now we were discussing about the further outcomes, if at all she conceives, we'll have to think about the further screening also. So we need to put everything in documentation whenever we are going to decide on anything, and the options of both the IUI as well as ICSI need to be told, because quite often when we stimulate them, these patients, suppose they get little over response, quite often we change our plan. And in that case, suppose the patient is counseled properly, it always goes in good way to get pregnancy. Yeah, thank you.
Thank you, sir, for those inputs. As we've already discussed, there are some basic guidelines that we need to be aware of. The last nice guideline on fertility was April 2017. Hopefully, we'll see an update sometime next year. There are some basic investigations which we like to advise all couples who come to us for treatment. And there are certain studies which we normally perform. Some of them may be evidence based, some of them may not necessarily be evidence based. But preconception folic acid, determining the rubella status, and giving some lifestyle advice is something which all of us do. These are very much pertinent and relevant, especially at extremes of reproductive age. As far as the NICE guideline is concerned, it is prudent to advise women that more than 50% of women more than under 40 years of age usually conceive within 6 cycles of IUI. Both your patients and the patient's patients may not be so much that they will undergo 6 cycles of IUI, as Dr. Rekha pointed out. So, good middle path is about 3 to 4 cycles, and then move on quickly to the next step, which is becoming more and more accessible now. That's IUI. Let's go to the next case. This is a 28-year-old. She is come to you for consultation, married since 3 years. She's trying since 2 years. She has irregular cycles. They come once every 2 to 2.5 months. Her weight is obviously more. She is very smartphone friendly and Google friendly. So she's Googled her symptoms and she has realized that she may have something called as PCOS. Now she's decided that she wants to undergo IUI on her own. She's come to you because you run a fertility service and she's asking you, doctor, how can I undergo IUI? How would you guide me further? Let's hear from Dr. Anurek.
Hello?
Yes, ma'am, please go ahead.
You're asking me? Your voice
Dr.
is
Anurek.
breaking. Okay, fine.
Yeah. Sir?
Yeah, go ahead.
Yeah. Yeah. Okay. So actually, this is probably a patient of anovulation due to PCOS, maybe with obesity and anovulation, I could conclude. And I would like to know whether she has undergone any previous treatment or she's a treatment naive person. So with that, like if she's going to be a treatment naive, so no other treatment has been done earlier, I would like to have the semen analysis done. And if the thing is normal, I would like to advise her for a lifestyle modification and weight reduction, first of all. And then maybe I will give her a time of at least 3 to 6 months or whatever it is. And with a lifestyle modification in hand, if the patient is be a treatment naive person, I would like to give her a ovulation induction rather than going for a direct IUI. And with the ovulation induction, I would like to start her with a chromosome or letrozole depending upon her ovary, like I would like to look whether the ovary is increased stromal thickening is there or not. Like with that, I used to judge whether the patient would respond with clomiphene or I have to give her letrozole. And then if the weight reduction and ovulation induction with 3 to 6 months, if she doesn't conceive, then I like to go for the further steps.
Any difference of opinion here? Can I ask Dr. Reema to contribute? I think she is now back with us. She was missing for a little while. So, do you have a difference of
Hello.
opinion? Do you want to offer her clomiphene or do you want to try something else?
Hello, good afternoon, first of all. And secondly, there was some audio issue, so I could not hear the entire thing, but I'll just give my opinion. So, yes, of course, in her case, as Dr. Anurekha said, that it seems to be an anovulatory kind of infertility. So, yes, first of all, I would also want to go with the lifestyle modification and, advise her probably weight loss. And of course, and I'll tell her the importance of weight loss. I don't want a little bit of, even if she comes down to, 66, 67 in her case would be good enough. If not entirely beneficial, it will at least decrease the dosage of gonadotropins or whichever ovulogins I'm going to use in her. Then probably in 1 or 2 months, I'm going to reassess her again. And I will actually want to give her a cycle of IUI, but I'll also explain what IUI does. And so IUI alone is not going to benefit her unless combined with OI. So yes, I will. I personally have stopped using clomiphene at all in my practice, and I directly go to letrozole. And it has been giving me, better results in CC because of no endometrial problems. So I normally prefer letrozole. In her also, I would like to go ahead with that, along with metformin and lifestyle measures, and plan an Iui cycle for her.
So we have two different points of view, but both of them more or less are suggesting that we should resort to oral ovulogins while doing an IUI cycle, especially in a patient who is a PCO patient.
Yes.
Any other inputs? Can I have Dr. Rekha's point of view on this? Do you want to do an IUI cycle with oral ovulogins or do you want to resort to gonadotropins?
Can you show me the slide? That's her history slide.
Just one second.
No, it's not.
Yeah.
Yeah. She's 28-year-old and married 3 years, trying since 2 years. Clomiphene is out of my practice. I try letrozole in few patients, but I have had my personal experiences. I have had very good success with gonadotropins with IUI. I start with only HMG and give them IUI. This is my combination, and I'm quite happy. And I feel it's around 5-10% more than what I was doing with letrozole. But according to many and according to textbooks, according to so many studies, letrozole is quite a good drug. But I use in those patients where they don't get follicles, where I have to give many number of days of injection, the resistant kind of PCOS. So those are the patients I give them letrozole and then add gonadotropins or longer days of the letrozole. But if I feel everything is okay with her, like not a resistant PCOS, those kind of patients, those who are responding well, those kind of patients, I take them directly starting with HMG and not letrozole, and controlled ovarian stimulation with HMG and then give them IUI. This is my view. This patient needs a lot of counseling, and because she has done a lot of Googling and found out many things about herself. So definitely she'll pose so many questions to me: why gonadotropin, why not letrozole, those kind of things. Of course, and as Anurekha said, the weight reduction and those of things have to be supplemented.
So coming back to the weight reduction issue, if somebody's BMI is above a certain point, should we stop and should we tell them that you first need to prioritize your weight management and then do whatever fertility treatment? Or should that happen side by side? Dr. Tomar Madam, what is your point of view? Interestingly, Dr. Tomar Madam comes from Ulhasnagar, where most average patient's weight is around 100 kilos, not less
Yeah.
than that. So that is why I specifically want to ask her, what is her viewpoint?
That Pratik, point is these patient, this PCOD patient, after 2 year or 3 year of marriage, they are very desperate. So on first visit, we do the counseling. Your success rate is going to be better if you are reducing your weight. So you start diet. At our hospital, we are having a dietitian. So we used to ask you come and every 15 days meet her and do the diet counseling, do the regular exercise, and I will also try my best from the medicine point of view. So in this patient, we give 3 months time to them. Within 3 months, even you are coming down to 10 kg, that will help quite a lot. Number one. Number two, we do only stimulation and plant contact with the letrozole, and just call her for the follow-up on the day 10 to see whether with the only letrozole she is responding further or no. Suppose within 3 cycle, if it is not going to work out, then I will ask them, now is a high time, you go for the IUI. For IUI, every cycle, every patient, I take the letros with gonadotropin, because I just want little more follicle, but because she is PCOD, so we have to be little careful how much dose of the gonadotropin we are giving. So first 3 months weight loss along with plant contact along with letrozole, we start. Suppose within 3 cycle, if she is not conceiving, then 4 cycle we used to ask for the next IUI cycle. Even after 3 cycle in IUI, she is going to fail. Definitely, I would like to go for the laparoscopic ovarian drilling.
Thank you, ma'am. Can we hear from Dr. Milind Shah, sir? Specifically, I wanted sir to address the issue of how a small change in BMI can impact fertility results in a big way. Do we have sir with us?
Yeah. Yes. Pratik, I'm very much here. Yes, it's a very valid point. See, basically, patient has Googled. And now she's trying for the IUI without, thinking of the other factors. Quite few of our patients, they feel the IUI is the panacea of treatment. That's not true. One need to speak with them. We should tell them about the limitations of IUI as well. And as now she's having irregular cycles, her weight is 75 kg, we definitely need to think about the all adjuvants as well as the lifestyle changes. And the induction with time intercourse has its own way to get conception. So we definitely can give her at least 2 to 3 cycles. Her age is 28 years, but it all depends on her previous 2 years where she was anxious to conceive and probably must have undergone a lot of things. If nothing has been done with in the last 2 years, definitely we should be open enough to have the time intercourse as also option before subjecting any patient for IUI.
All right, sir. Thank you so much, everybody. Anybody else who would like to contribute and before we move to the next case?
So I also feel that an option of sequential treatment is also a very good option rather than
All
directly
right.
jumping for gonadotropins. As in what Dr. Tomar said is she has a good result with gonadotropins. I feel that a combination of letrozole with gonadotropins also works very well, because with gonadotropins it works as a double-edged sword. The chances of OHSs and multiple pregnancies go very high. So if you feel that the follicles are not getting stimulated, or then sometimes I feel if you can start with letrozole and then maybe add a small dose of gonadotropins, it works better also. And there are multiple randomized trial studies which are done. And in fact, in our practice also, I feel that dosage is also less, chances of OHSs also go down, and it works also better economically to the patients. So
Thank you.
in these PCOS patients, I think it works better.
I would be
We had
happy
in
to
IUI.
start with the HMG itself, because one is she's been anxious to conceive since 2 years and should have tried, and she's an educated patient, tried googling and all those kind of things. And third is all studies have shown that gonadotrophins basically give a better result, and nowadays the patients don't mind by paying little extra more, but they want their work to be done and go out from our clinic with a good result. And OHS is in our hands. Like when you are managing her with a regular sequential ultrasound scan, when you know that follicles are more 3 follicles, whatever we say regarding OHSs, then you can anyway cut down on that cycle. Like you can cancel that cycle, again convince her and go for the next cycle. So I will not take gonadotrophin out of my list.
Even
I
I
think
want.
Rima wants to say something. Yes,
Yeah.
Rima, go ahead.
I just want to make one point that they cannot be like the last case we made this point, that they cannot be one rule for one scenario, because PCO in itself is such a diverse spectrum. It can be as mild as has it's picked up as an incidental finding, to as severe as sometimes in IVF also it fails to give any results with highest dosages. So I think to whichever way it works, but it has to be evidence based, and one modality is, you cannot overlook things, and it is upon the patient's need and their, kind of background. You need to discuss all the options to them. You give them all the options, you discuss each pros and cons of each option and let them decide. First of all, they feel a part of it, and secondly, the results can go either way. So when you involve them with the decision making, I feel it is more fruitful.
Thank you, ma'am. So we've had multiple opinions from all of our panelists. Yes, somebody was saying something.
Yeah, I was just adding a single statement. Thus, ultimately, I feel it is the combination of one, weight reduction, and second is the experience of the practitioner on the ovulogen, whatever they have been using. Thank you.
True. So in this particular case, I mainly wanted to discuss the issues of weight and obesity, but we've got diverted into gonadotrophins. There was another case where we were going to discuss gonadotrophins in detail, and we will do that a little later. But here, what I wanted to emphasize is that sometimes we tell our patients that "Pehle वजन कम करो, then we will treat you for fertility," and the patient may never come back, either because she doesn't agree with that approach, or because she is not being able to lose weight for various reasons. She may have some hormonal issues, she may be genetically predisposed to that, it may be that exercise, whatever you have advised, is not working, or she is not compliant for various reasons. So don't take patients out of fertility treatment programs simply because their weight is a little bit on the borderline side. That's the take home message. Of course, if the weight was 100 kilos here instead of 75 kilos, like most patients who come to Dr. Tomar, then that's a different discussion altogether. And we will come to that also a little later. The key here that I wanted to convey is that don't try and exclude patients from fertility programs. We know what the guidelines are for Indian patients. They are a little lower and they are different from Caucasian patients. And while being aware of these guidelines, it's also important for us to realize that with every 1 or 2 points increase on the BMI scale, your fertility reduces by a factor of as much as 30%. So we have discussed lifestyle modification, weight, exercise, ad infinitum at various different era over the past 5 years. In practice, it works sometimes. Many patients who come to you, if you are practicing in a large metro, have already gone through the entire gamut of lifestyle reduction, lifestyle weight modification. All those things have already been done, and they want quick results. That is where sometimes you need to err on the side of caution, move them quickly into the IUI assembly line and try and achieve pregnancy as early as possible. At the same time, it is necessary to counsel patients, talk to them as a couple, emphasize that a reduction in weight will result in better ovulation, better quality oocytes, earlier chances of pregnancy, shorter time to pregnancy interval, and finally the incidence of complications in pregnancy once she finally conceives are also going to be significantly lower. We fail to mention that sometimes to patients. And once they realize that all of this is going to contribute to complications later in pregnancy, they sometimes are little more motivated for weight reduction, lifestyle, etc. Insulin sensitizers are going to help. Whichever insulin sensitizer you choose, whether it's metformin or it's the newfangled ones, your choice may vary, and finally, they will have a beneficial effect. The entire crux of today's discussion was on IUI, and we would be failing in our duty to discuss IUI if we did not discuss IUI for male factor. So let's talk about this couple. They are married since 2 years. They are trying to conceive. Husband's count is quite low. Motility is also quite poor. He's been advised surgery because somebody found that he may have varicocele. Let's hear from somebody who has not spoken earlier. I saw somebody traveling in between now. Everybody's have a chance. Let's hear from Dr. Rima. What would you like to do for this couple?
Okay. So as already pointed out, this is a case of male infertility.
Yes.
HSA is 10 million, 20% motile. Now, of course, whenever we deal with male infertility, the first thing to do is to get an examination done, and there is a finding here. There is a mild varicocele. So I will obviously sit down for the counseling first and explain it to them that we are dealing with. I mean, the treatment will be, will be a teamwork. There's one issue is the reproductive point of view, and the other is the problem that he is facing, and so which we will continue with the urologist as it is, and they will be the best person to advise. But what I will tell them is that they should not be really waiting for that treatment to finish so as to complete and come on to their reproductive treatment. So I will tell them usually this is a severe kind of male infertility, and varicoceles are known to cause OATs, oligoathenoteratozoospermias, and usually even after treatments, sometimes in mild varicocele they are beneficial, but not always. So I will definitely first of all give them some antioxidants for at least 2 months, preferably 3 months, but after that, because even for IUI, I would want, even when I'm doing an IUI, I would want it to be a justified cycle. I don't want it to, repeat. I don't want to go to a second cycle. So I will send them to a urologist. I'll plan an IUI cycle for them. And yes, what else to say?
So Dr. Rima feels that with treatment in the shape of medical management, with antioxidant therapy, the counts will improve, and that will help us to achieve a pregnancy if we try with IUI. And if that fails, we always have IVF available. So we'll go in a step-by-step fashion. That's what she said.
This is severe one, and of course they should not expect miracles. A 10 million, 20% motile will not, go on to some 50, 60 million, but even a little bit of improvement in the health of the sperm will definitely increase, because not all even the healthy looking sperms, DNA the studies have been there, but DNA has been found damaged. If I can work upon that, and varicocele especially is that kind of a condition only which does produce that kind of damage. So to work a little, to bring the patient up to that procedure optimally, to optimize that, I would want to do that. But of course, not delay a lot, because this is a severe kind of problem that he's having, and the mild varicocele might not even be the causative reason, cause for this.
So let's ask Dr. Tomar, madam. Madam, this patient comes to you and says, "Madam, you have been in practice since 3 decades. We have come to you with a lot of hope. Is operation required? Is surgery required for this patient? कि बिना operation से हो जाएगा? क्या करें?"
Pratik, this patient, before commenting anything, I would like to ask whether this 10 million per ml, the count is there, or total count is 10 million?
Total count.
Total count is very low. So before commenting on the varicocele, because mild varicocele is not operable, surgeon, they don't advise to operate. And after operation also, we cannot give the success rate. So this patient definitely, I would like to do all the other tests also, for the hormones also, for the infection also, and sonography, color Doppler, what's the scenario inside. And after giving at least 3 months for the medical treatment, I would like to repeat the semen count, because spermatogenesis, it takes 3 months time to come to little better. So I will advise them to go for the planned contact also, take the 3 months treatment also. And in treatment, we have to supplement all the, if all the blood report is coming normal, hormones are coming normal, nothing is wrong. In sonography also, there is no hydrocele, no infection. So diet, exercise, we have to, even the male, we have to tell them for the have the healthy diet, do the exercise just to improve the blood flow, just stop all the smoking, alcohol, everything what can be the toxic. We have to ask the medical history whether he is taking any medicine that can also cause the oligospermia, because mild varicocele we cannot think of this is the only cause for the oligospermia, and this surgery is not going to give the better effect. So everything, his local examination, lifestyle, we have to ask them. We have to do the color Doppler and see the blood flow in the testes, and all the things are coming normal. Then just try to give the 3 months medical treatment, repeat the semen examination after 3 months, because doing every month semen is not going to be helpful, because total spermatogenesis is going to take that much of time. And till that time, we advise to have the planned contact on the ovulation time. Suppose after 3 months, he is not getting any improvement, then definitely I would like to go for the Iui cycle. That is also going to fail, then IVF definitely. So one by one, we have to investigate what's the cause for having the oligospermia, what type of job he is having, how he is working, what's the atmosphere over there, what's the diet, what's the habits are there. So everything we have to work out on that male partner. And we have not to rush immediately for the IUI. At least 3 months, we have to give the medical treatment, plan contact, and repeat the semen after 3 months. So this counseling part is very important for them.
So specifically, any specific antioxidants or agents you would recommend with which you personally had good success since you have such an extensive practice? Any specific agent you would recommend?
Now we are getting a lot of combination of all the
Correct.
antioxidant. Market is full of every day 20-25 mr they come with their own product. So basically we have to tell them for the exercise, have the healthy diet, lifestyle changes, plus antioxidant we have to give. Because varicocele, there is no medical treatment, mild varicocele. So that's the thing, and just wait and watch for the 3 months. Just have the planned contact and see the result, whether it's working out or no.
So probably the entire panel is in agreement that surgery is not indicated in this case because the total motile sperm count is quite low and it's only a mild varicocele. Typically, these patients don't respond well to surgical management. Medical
Dr.
treatment
Pratik, can
would
I
be
add
one of the
something here?
important things. Yes, ma'am. Please go ahead.
Yeah, I would beg to differ from Tomar madam a little bit here. In the sense, she said that she will wait for 3 months with antioxidants with the semen sample. Probably, if the repeat, I may repeat the semen sample. Suppose the repeat semen sample is also around 10 million only, then I will directly take her for IUI because the chances with IUI itself is low. So chances with natural conception sitting at home for next 3 months may be a little bit differing the treatment in this case. And I would also have some information from your side regarding the morphology of the sperm and also the female factor. Like if female is also not so fertile and his DFI is more than 40% or sperm morphology is also bad, probably they can be directly promoted maximum after 1 or 2 IUI cycles, that too for our and their satisfaction. Probably we can hasten the procedure and directly take them for IUI if they are on the flip side.
So what we would do is, sir?
Yeah, go ahead. Go ahead.
So what I would like is that I know there are a lot of antioxidants, but because here the count and motility is low, we would like to give a combination, especially which has L-carnitine and coenzyme Q, because they mainly work on the motility. And antioxidants, if you are giving, it has to be at least given for a period of 3 months. So if you are thinking about an IUI, and also the count and motility is important, but the total motile sperm count is very important. So that is something that has to be seen, and that has to be more than 5 million. That has to be seen for the IUI, and if that is more than 5 million, then you can think about an IUI, or else maybe then you can think about an Iui cycle.
Sir, even I agree with Madam Sir. Like with
wonderful
this
discussion.
patient, mild varicocele, if diagnosed incidentally, it may not be the cause for this 10 million total count or 20% motility, I think. So
Yes.
if everything is normal, including the endocrinological parameters of the male, and if there is no reasons other than this mild varicocele, if nothing has been found out, if the total motile fraction, like with this result, I don't think the total motile fraction will be of 5 to 10 million or whatever it is. So if the volume is normal, 2.5 ml, whatever it is. So if the total motile fraction is, I would prefer 5. I would like to have a threshold of 10 million. If the threshold is 10 million, then I would like to go for an IUI. Otherwise, ART will be the option.
So this entire case was to convey some important concepts, and let's hear a summary from Dr. Bilincha, sir, our expert.
Wonderful discussion. I'm really enjoying, the various opinions. See, but certain basic things we need to again recall. That is very important. And one, that quite often the semen parameters doesn't correlate with the fertility potential of the sperms. So one need to take that into consideration. So, why I'm saying so, quite often when these husbands come with these reports, they're quite nervous. And as compared, we say the women are more tender, but in this matter, the men are also very tender. So always tell them that suppose I choose 5 fathers from my OPD who already got babies and I do semen, quite few of them may be having this low count, or they may be having little less motility, but they have, automatically they have proven their fertility, because as I told you, the semen parameters doesn't correlate with the fertility potential. And that's why we always say the test for the semen, the sperm potential is the pregnancy. So one need to actually think about that particular factor as well, which is absolutely multifactorial, why the count actually comes that way. So one need to think about all the other options in a sequential manner, one after other, by investigating thoroughly this oligospermia and by adopting whatever best we have. Many of those things are empirical, because we know that even by doing hormones, the best definitive treatment is only possible in 1% of those cases where there is a hypogonadotropic hypogonadism. Otherwise, quite few of other cases where we need to think of empirical, what antioxidants and other adjuvants, vitamin C, a course of antibiotic, doing semen culture, and all those things one need to do. But yes, we have both actually options available for this particular case, where we can think about the natural conception as well, which is less likely, consider it that way, but not impossible or totally negative. And of course, the IUI is going to augment that particular semen to get a better fertile sperms, which can be inseminated in the uterine cavity. Thank you.
Thank you, sir. So I just wanted to ask the panel one final question, and that is, what is their specific antioxidant of choice? We've already said that there are many combinations that are available in the market, and each pharmaceutical company has its own preferred combination. So as practitioners, is there anything specific that you like? I think Dr. Sheetal mentioned that she likes L-carnitine and coenzyme. Do the other panelists have any specific option that they like to practice? Yes, Reema?
यही देखते हैं, और एस्ट्राजेंथिन भी होता है कॉम्बिनेशन.
Astaxanthin, yes, astaxanthin is a good option. Yes. Anurekha,
sir, I don't give the combination, sir. Sorry, actually.
Okay, you like monotherapy. That's a very good option. Yes.
I used to start with vitamin E, vitamin C, and zinc alone. So, but the dose is also like with vitamin E, Evion or whatever is available. I used to give 400 milligram once daily. And vitamin C, I used to give this Lim C or whatever is chewable vitamin C. I used to give BD. So it will come around some 200 mg per day, vitamin C. And then zinc, I used to give 100 mg per day. So this Ascazin and all, the brand available is Ascazin. It gives a 50 mg tablet. So I used to give 100 mg per day. Actually, the recommended one, according to a lot of studies, is around some 140 milligram of zinc or whatever it is. That is the one I think I remember. But we don't get any such combination tablets like 140 milligram zinc. Usually the combinations contain 10 or 15 milligram of zinc, which is very insufficient for the antioxidant property needed for improving the semen parameters. So I don't use a combination. Right now, I've not used it.
So there are plenty of antioxidants that are available, and depending on the financial and purchasing power of yourself, your patient, and the population that you cater to, probably there is either monotherapy or combination therapy to suit all ranges of financial prowess. So I think we've talked a
So
little bit
is
about
1 minute. Is
that.
ubiquinol the active form of CoQ
Can we
coenzyme?
come to that in a couple of minutes, ma'am? Do you mind if we do
Fine.
that? Okay. Right. So as far as oligoasthenoteratospermia is concerned, there are some basic steps that all of us like to follow. Physical examination, which we almost rarely do in clinical practice today because of social distancing, COVID, and all the other things. Plus, many of us find it distasteful as well, and that is why we often send these patients to a urologist or a general surgeon who will take care of that. And we've already talked about varicose surgery. We know about the semen parameters. We have talked about the various different reasons for oligoasthenoteratospermia. If we find a varicose, we are very happy to blame varicose as one of the important reasons, but often you will find that one-third of all patients, it is idiopathic, and the varicose is something which is just concurrently present. There's a new guideline which has been published by ASRM, and this is published in Photosterol 2020, and you can go back and read this. There is a very nice algorithm that they have come up with for management of fertility, and varicocelectomy is one of the options that they've mentioned, but that's something only if you have a large varicocele, which is obvious, and where the varicocelectomy is going to be of clinical benefit as per the second opinion from a urologist. For mild varicocele, typically it does not help. The concept of oxidative stress and reactive oxygen species is known to most of us. We know that there are multiple lifestyle factors, including smoking and alcohol, plus sitting for a long time in front of the computer, which all of us are doing for the past 2.5 years, can also contribute to these issues. Somebody pointed out that DNA damage does happen in patients who even have borderline oligoasthenoteratospermia, and therefore Dr. Minsha pointed out that semen parameters do not always necessarily equate to fecundity. Somebody who has borderline count or co-count also is capable of having a natural pregnancy. We know that this DNA damage can be identified with certain specialized tests, like we mentioned earlier, including the morphology and the DNA fragmentation test. Rita pointed that out. And as far as the specific antioxidants are concerned, we need to give vitamin C and E for very high doses if your patient cannot afford anything else. That is offered by Dr. Rita. I remember L-carnitine was mentioned by Dr. Sheetal, and one of the important agents which helps to improve mitochondrial energy and generation of ATP, but you need to give the appropriate dose of L-carnitine 3 to 4 grams per day. Lycopene is anti-inflammatory. We know about lycopene. Astaxanthin was mentioned in passing, and astaxanthin works very well. In fact, it gives you 34% improvement in fertility, threefold improvement in fertilization rates, and it's supposed to be about 300 to 400 times more potent than vitamin C and E, which are the poor man's antioxidants. You'll find that pregnancy rates, very few studies will report, and there is a 40% plus improvement in pregnancy rates if you prescribe astaxanthin. Of course, you need to give it for at least one spermatogenesis cycle, which is 90 to 120 days. As far as mitochondrial energizers are concerned, coenzyme Q10 was mentioned a little while earlier. It helps in the mitochondrial energization, improves your semen motility, sperm motility, and fertilization rates as well. In fact, ubiquinol, which is the reduced form of coenzyme Q10, Dr. Rekha was mentioning just now, increases the sperm density and motility by a significant amount, also helps to increase the sperm penetration in assays. Whether it translates into improved pregnancy rates, that's something which we will only know once we do larger studies, but small studies show that there is significant improvement in your motility as well as morphology. You prescribe coenzyme. Dr. Rekha, you wanted to contribute something about coenzyme. I see she's frozen. Some internet issues.
Yeah. One
Yeah,
more.
I'm out of disturbance.
Yeah, go ahead.
Yeah.
Dr. Milind Shah, you wanted to say something?
Only one more actually message one we need to convey about this varicosilectomy. Nowadays, the microscopic actually varicocele ligation is far better than what we used to the conventional, because it can reduce so much of morbidity in that particular male, and the result wise it gives a good result, but of course not for this particular case as it was mild varicocele. But in advanced cases, many will advise always and always opt for the microscopic, actually the varicocele ligation, which is available at many centers in many cities. But again, we need to be aware of that particular fact as well whenever we are thinking about it.
Thank you, sir. So, ubiquinol or reduced coenzyme Q10 helps to significantly increase motility, especially where motility is a concern. The total count is absolutely okay or borderline, and there are significant improvements in motility as well as concentration once you prescribe these. There is one old Cochrane meta-analysis which was published quite some time back, and that shows that administering the antioxidants significantly improves pregnancy rates as well. As far as the choice of antioxidant is concerned, there is no one size fits all, as the panel has pointed out repeatedly. You choose what you feel works in your population, in that particular couple which is sitting across the table from you. The next case is the one which we were going to discuss extensively about gonadotropins. And this is the lady who has clomifene resistance. So let's start talking about clomifene resistance and what options we can offer our patients who have clomifene resistance. Dr. Sheetal, you want to start the discussion?
Yeah, so basically, I would like to start with what is the definition of clomiphene resistance, because a lot of people think that clomiphene, there's a confusion between clomiphene resistance and clomiphene failure. So, clomiphene resistance is basically where after giving the highest dose of clomiphene, that is 150, the patients don't respond at all after 3 cycles. And clomiphene failure is that patients ovulate and still don't get pregnant. So, that is first the main difference. And now, what are the options? So, either you can give, so if this is the case that we have, you can either start with letrozole, that is now the first line treatment for clomiphene citrate or PCO patients. And that would be my drug of choice, in fact, for this patient, because she's 34 years and she's never taken. And I would do a sequential treatment with letrozole, and if she requires gonadotropins, if the follicle doesn't develop, looking at the ultrasound findings. And as Rima said and Dr. Tomar said, it depends on how it goes. I know it is case to case basis, but again, believe me, it is a double-edged sword, as I always say. They shoot like anything. I've faced so many patients where it is very difficult, and you don't want to cancel a cycle when you're doing an IUI cycle, because patients get really depressed. So in this case, I would like to start with letrozole.
When you're using gonadotropin for an IUI cycle in a patient who has clomifene resistance, what are the tips that you can convey to the audience from safety point of view? How many follicles for? What should be your starting dose? How do you titrate? How do you monitor?
Yeah. So whenever you're doing a PCO case, your target is to stimulate one single follicle, because in PCO, your aim is not controlled ovarian superovulation. Your aim is to ovulate one single follicle, because here the patient is anovulating and not ovulating. Here your aim is to ovulate one single follicle, And that's why you start with the lowest possible dose, maybe 37.5, or maybe when you think there are resistant follicles, maybe 75, because the threshold might not cross. So maybe 75 IU or something, depending on how you feel the ovaries are, or what her AMH is, or what her BMI is. Maybe because her BMI is higher, she might not respond with 37.5. So in her case, looking at her ovaries or maybe her antral follicular count and her AMH, you can decide what is the best dose, and you can start accordingly if you are giving her gonadotropins.
So I think that's a good starting point for the discussion. Use gonadotropins, use the lowest possible dose, look at the antral follicle count and the AMH on day 2 to 3 of the cycle, and then take it from there. It has to be obviously done by you directly in close
Yes.
supervision. It should not be delegated to somebody else. Dr.
And
Anurekha,
the
let's
scan.
have your views. Yeah.
Yes.
Yeah.
Can we have your views on which gonadotropin to use and how would you monitor such patients?
Sir, I would prefer to have a letrozole with gonadotropin combination
Okay.
for CC resistance. And one more thing, here I presume that she is a case of PCOS, her tubal evaluation has been documented, and her semen analysis is normal.
Correct.
So my option will be like with letrozole and gonadotropin instead of going for a gonadotropin, because what I have experienced is with the letrozole and gonadotropin, there is a decreased chance of hyperstimulation along with the need for decreased dose of gonadotropin. Because any of the effect of letrozole of monoovulation is maintained with gonadotropin rather than going for only gonadotropin. So that is what's good. And along with that, her lifestyle modification and everything has to go on with whatever
That has to
treatment
happen
is involved.
simultaneously.
And metformin will also be an option to be added. Metformin plus myoinositol, or either metformin alone, depending upon your choice. So that is what I'd like to say.
So an insulin sensitizer will help to reduce the incidence of hyperstimulation syndrome and maybe to a certain extent improve the site quality and better results. Dr. Nima, your choice of gonadotropin in a PCO patient who you are stimulating for IUI.
For IUI, sir, HMG is good enough. But
is good enough.
But I also, I know studies have shown that all gonadotropin, starting directly from gonadotropins, has given better results. But even I like to try a sequential first and always add metformin in an overweight patient. I may forget it in, unexplained infertility or for any other cause that I am doing OI. But for an overweight patient, I have, at least in my practice, found metformin to be useful. And I started a month or 2 months prior to I planned this. And letrozole I start with, CC I've totally given up, and HMG again 75 or 37.5 depending upon the BMI of the patient. And if in that cycle, if it does not give me results, it at least teaches me a lot of things. And if I have to, because a lot of times we are only looking at the follicle, and there are other especially in such kind of patient, there will be other metabolic disturbances as well, which need to be looked upon. The luteal phase may not be in sync and other things. And the reason of not getting, all these failures, CC failures and now that we are talking about may not be because ovulation part has been taken care of, but there are other factors as well. So if this cycle sequential may or may not give me my desired results, but it will teach me how to plan my next cycle better. And then I have done all gonadotropin starting right from day 2 also. That again depends upon patient to patient.
Right. So Dr. Rima is of the opinion that HMG usually gives equivalent results to FSH. You need not necessarily make the patient spend more. And if the patient is affording, you can start with gonadotropins right from day 2-3. Or if you want to err on the side of caution, or you want to reduce the cost of the cycle,
also, sir,
you can give letrozole with HMG. Yes, ma'am.
Also, sir, there have been studies which have showed that the live birth rate or even the pregnancy rate, it necessarily may not go up with addition of gonadotropins, but the risk of multiple pregnancy, it's not OHSS that I am worried about, multiple pregnancy after an IUI, I think that is something that I am worried about. So multiple pregnancy definitely goes up with with addition of gonadotropins, and coming out of an IUI cycle, I'm really not that keen on that.
So therefore, you need to aim for as few follicles as possible. And in an ideal world, we would like to achieve what is called monofollicular development. That may not always happen. You may land up with 2-3 follicles. So let me ask a very practical question. What is the point where you say that you don't want to do an IUI in this cycle? Dr. Rekha, is there any particular number of follicles at which you would say that no, we don't want to do an IUI in this cycle, we want to cancel the IUI?
Yeah, there are certain, when we monitor these patients, suppose the size of the follicle, if each follicle is more than 15 and such more than 3 follicles, then I will abandon the cycle. Or if it is more than 12 and such 6 follicles and beyond, probably I'll cancel the cycle for that IUI.
So when
because I'm scared of
cycle,
or I can convert to, or I can convert it to the IVF cycle, like the counseling, however it goes, which will not continue as IUI.
That is an option which may not be available to a general gynecologist who doesn't have access to a center or an IVF center. So when we are cancelling, in inverted commas, the IUI cycle, what instructions do we give to the couple? Is it okay if they go and have
the natural? No, do not have the natural contact, because that also can cause, because we have already stimulated you halfway through, that can result in pregnancy also. So don't have to abstain from contact till you have your next menstrual cycle and everything falls back to normal.
Perfect. Dr. Milincha sir, any closing remarks from you regarding the choice of gonadotropin dose and how we monitor these women so that they don't explode?
Yes. Basically, in PCOS, we always prefer FSH over the HMG because it gives a better actually outcome. But all said and done, I always remember Professor Spirov's actually the linings in 1970, what he has written, that somehow these oocytes in the PCOS have a incompatibility for the reproduction. And that's why whatever gonadotropin we are going to actually utilize, we'll have to understand about its limitations, that how they are going to perform when it comes to the success rate. And that's why when the age is 34 years, her weight is 90 kg, has undergone ovulation induction, then we'll have to think about the further options as well when we are thinking about the IUI. But yes, still, if you feel that the tubes are patent, patient is willing for waiting for 2 months, we can think about it. And the induction process, again, we'll have to individualize. Monitoring is very, very important. As you said very correctly, the costing and the cancellation of the cycle need to be thought about. Whatever gonadotropin we are going to utilize to avoid all those problems related to the OHSS.
Thank you, sir, and thank you all the panelists for.
One point I'm certainly remembering.
Yeah. Yes.
A lot of times when I have cancelled a cycle, I saw, okay, there are 3, 4 or 4, 5, 14 so I just cancelled it. But once or twice or more than that, I called them, like I did not give them anything beyond that, gonadotropins nahi diye, but I called them, 3 days later or 4 days later. And what do I see? That the rest had stopped growing beyond.
Yeah. Yeah, that's what costing is. Yes, Rima.
Basically costing.
Yes, sir. So, I mean, एक scan कर लेना चाहिए, because I went ahead with trigger and IUI and I got pregnancy. Like, बिल्कुल cancel करने की बजाय एक बार scan कर लेना शायद ठीक रहेगा. Because they've already spent on gonadotropins.
Practical point. We've already talked about clomipene resistance. How now we should be thinking of letrozole as the first choice, and clomipene is something which we don't practically use much because the success rate of letrozole is significantly higher. As far as gonadotropins are concerned, the Cochrane meta-analysis says that it doesn't matter whether you use HMG or FSH, as long as your cold chain is maintained well, the correct dosages are administered, and you have a cafeteria choice as far as HMG is concerned, because the cost per cycle is quite low. Ovarian drilling is something which I don't want to discuss today, because in a PCO patient at the age of 34, we should not be thinking of ovarian drilling. Use the smallest possible dosage. Make sure that you monitor personally. Whenever in doubt, refer to your friendly neighborhood IVF specialist, whoever you trust, call them on the phone, inform them, intervene early if you feel that the patient is going in for an OHSS, and ensure that when you cancel the cycle, you counsel the husband and the wife both that relations may not be maintained in this cycle. If at all they have, then they should use barrier contraception. Otherwise, she will land up with a natural triplet or a quadruplet, and then you will be in major soup. The next case is a lady who has already undergone 3 cycles elsewhere and she doesn't want to undergo IVF. So, what should we do for this lady? This is a little difficult clinical scenario. She's 32 years old, she's married since 5 years. Dr. Tomar, madam, what would you like to offer her? She's already undergone 3 IUI cycles. We know that statistically the chances of her conceiving with an IUI after the first 3 cycles are going to be lower. So, what permutations, combinations, modifications should we offer to this lady so that she gets a better success?
Pratik, in this patient, definitely because she has not taken the gonadotropin. So first, I will counsel them ki whatever the oral medication they have taken, that is causing the monofollicular development. And once we are adding the gonadotropin, because of the multiple follicle 2 or 3 we are getting, so we can have the better chances. That's the one counseling we have to do. So if she is willing, we can try with the gonadotropin at least for 2 cycle more. Or if she is not at all willing for the IUI and want to know what's the cause, then definitely I will take for the hysterolaparoscopy, do the biopsy on PCR to find out what's the reason for that. Suppose husband is absolutely normal, that's why she has gone for the IUI. So one counseling I will do for the IUI with gonadotropin. Second counseling, if she is not willing for that also, then definitely I would ask her to go for the hysterolaparoscopy and find out the cause, what is wrong over there.
Thank you, ma'am. So let us hear from Dr. Rekha. This is in inverted commas, maybe unexplained infertility, where everything is normal and you presume in good faith that everything is okay. You go ahead and keep trying cycle after cycle, but after 3 cycles, she is mentally exhausted. You are also exhausted because you can't give to the patient. Is it now time to do a hysterolaparoscopy and, as Dr. Thomas suggested, do an endometrial biopsy, rule out endometritis, rule out intrauterine pathologies as a cause of failed fertilization of the infant? What do you feel, Doctor?
I would like to add certain things here. One, since she does not have brought any previous records, we are not sure what has happened. Like they might not even done certain times. Surprisingly, they might not even done HSG to know the intrauterine or the tubal pathology. So I would like to revise the things. If not laparoscopy, at least I will go for a combination of office hysteroscopy with HSG, where it's a little lesser version of, because she does not have to be subjected to anesthesia here, and I can do both as office procedures and send her. So I will do these two, and then with gonadotropin, if these investigations turn out to be normal and the semen analysis turns out to be a normal, because she does not have any reports, if all these 3 basic parameters turn out to be normal, and since she tried only with oral medication in previous cycles, I will augment the cycle with adding gonadotropins and antioxidant to both of them, counsel them for another 2 more IUI cycles, 2 or 3 IUI cycles, with the backdrop of IVF, counseling about the IVF. That after 3 cycles also, with all the investigations being normal, you have not conceived with best of everything of 3 IUIs. That means 6 IUIs are over and your success rate is not going to be good. And you are already 32 years and also trying since 5 years. Nothing has happened. So better go for IVF.
Good. So gonadotropin IUI is what would be suggested to this couple. But before we offer gonadotropin IUI, we need to be on very solid ground. Dr. Rima, how often do you see patients in your practice where there are no previous files of reports available? Does this still happen?
Very often, sir. There are 2 sets of people. Either they have this many investigations, they want you to have a look and everything, or they will not have, they would have burnt it off. They
will bring the bill also, pinned properly in the file.
So sad.
Let's hear from Dr. Milenka sir what he feels should be done for these unexplained failures or unexplained infertility.
Yeah, a very good question. You know, whenever these cases come with unexplained infertility, always feel that there are certain subtle defects which we are missing. And those are the cases, that's why they get benefited with IUI or our control hyperstimulation. Because whatever obviously defects are there in this reproductive process, we are able to detect with our investigative approach. But all those subtle defects are sometimes they miss from our investigative profile. And that's why these are the patients, they get benefited when we stimulate them, we do IUI and they get the pregnancy. So always think that there are limitations to our investigations also. And there are not only necessarily the list of investigations, even the methodology. That also makes a major difference because there are so many laboratories and what is happening actually in on their tests in the laboratories. One need to think a lot on that. And that's why what our old teacher always used to say, that clinically correlate all those investigations and then you take your call when you are treating. So we can definitely think about the IUI or the supervision in cases of unexplained infertility.
Thank you, sir.
So, if I may add,
yeah, go ahead.
yeah. So, if this is a case of typical unexplained infertility, as you have mentioned, then she will need an hysterolaparoscopy. And if there are these endometriotic patches, I think it is best to treat them. And as per the NICE guidelines, they have said that you need to wait for 2 years and give them no treatment at all. And if she doesn't become pregnant on her own, then you directly jump to IVF. But definitely we don't do that, and we definitely offer her IVF, IUI with gonadotropins or with letrozole or something like that. But then that is what the NICE guidelines recommend.
True. So we need to put in a telescope, rule out endometrial pathology, also rule out endometritis and endometriosis. These are the two commonest conditions which lead to so-called unexplained infertility. Also, we take it for granted when we practice in metros that this so-called baseline profile, which I have mentioned here, is done for all our patients. Often patients who come to you without any records or records which have been spoiled or damaged or whatever. The tests have been done long ago, 4-5 years back. They are taking treatment for several years, and these tests may need to be repeated. Dr. Tomar, madam, how often do you find that so-called unexplained infertility is actually tuberculosis or endometriosis in your practice?
Tuberculosis is quite common nowadays, but endometritis very less on the hysteroscopy, but tuberculosis definitely there. And second, my problem is there are many patients, especially for the semen count. You will see there is a lot of difference from the different lab. One patient, if we are doing within 2 months or 3 months, the lab semen reports are very variable. So whenever you are doing the semen examination, you have to rely on your pathologist, whether he is doing or some DLMT technician is doing and writing all the things, fructose is normal, all the things are normal. So in my practice, this semen analysis makes a lot of trouble because patient already said, I did 2 times, I did 3 times, but I have checked it. Most of the time it was done by the DLMT person and pathologist has not seen only. So I always ask to everyone to do with some reliable pathologist. So that helps quite a lot to us, number one. Number two, nowadays, again, the genital cox has just coming out more. Undiagnosed when we are just treating patient not responding, and when we are doing the hysteroscopy, laparoscopy, then in biopsy is coming quite a lot positive nowadays.
I think we need to be aware that not all of us are blessed with having full-time embryologists and we can do semen analysis in our own lab. When we don't have facilities like that in-house, then ideally a good NABL accredited lab or an ISO certified lab. Dr. Rima, you were saying something? Go ahead.
The endometritis I have found very common.
Even me.
Different IVF failures also. When I don't remember exactly which CD23 or what, but there is a panel with the SRL lab where they have immunohistochemistry markers. Initially, we were doing that, and it came positive in so many patients. जिन्होंने पता नहीं क्या-क्या IVF failure के लिए करा दिया था, and they came positive with this. So now I have started adding this empirically, this clindamycin and doxycycline
Yes, yes.
when they are
Even I see a lot of endometritis patients, especially endometrial fluid in the endometrial canal. Lot of patients, sir, you see these kind of patients, and you treat these patients with doxy and metro. I don't give Clinda. I think everybody has a different combination, and you treat these patients, and the success rate has kind of improved a lot. Even I feel a lot of patients have these things.
If
So
you're
I
in a
think it should be a
tertiary referral practice where you are seeing only infertility patients, then obviously you will see more and more of these patients,
yes.
like Dr. Chittal and Dr. Rina pointed
Uh,
out. If you do an
Dr.
endometrial
Pratik,
biopsy and send it for immunohistochemistry, CD56K are the cells which are supposed to be identified. Dr. Rekha, yes, you were saying something?
yeah, I'm sorry to interrupt you.
Yeah, go
Extremely
ahead.
sorry. In extension of Dr. Tomar Madam's statement that semen analysis is done in different labs, the values are different. Similarly, in the previous slide, what you showed that unexplained infertility, that without the patient has come without records and with only oral ovulations. Similarly, it is like the semen sample is collected at home, then it is processed in a different lab, then it is transferred to another place for IUI. So 3 places are involved in one IUI. So this also reduces the success rate of IUI.
True. So you need to have in-house facilities wherever possible. And going back to the discussion on endometrial biopsy, endometritis, and endometriosis, these are common conditions which we are now seeing with regularity, especially if you are practicing purely infertility. Therefore, it is necessary that we try and make an effort to identify them early. So we talked about all the different treatment methodologies. This is a very interesting case. This lady is, I wouldn't call her elderly, but she's 38 years old. She's already had one child. Now her daughter is 7 years old. She wants to go for a second child. She's come to say Dr. Rika. And Dr. Rika, she wants to undergo an IUI. So before you offer IUI to this patient, what certain basic prerequisites would you like to take care of?
Yeah, first is she is become bit aged compared to her last pregnancy and delivery. So her fertility potential and also her husband's fertility potential has definitely reduced to certain extent. That part I have to counsel her. And second thing, I had an IUCD, and it will be in their mind that because of the IUCD I did, after removing the IUCD, many people do come to us saying that because I had IUCD, even after removal I am not able to conceive. That part also I have to counsel her. And third thing is she has to have all the investigations, the basic investigations, like as you said, the TSH, prolactin, HSG, etc. done afresh, because you really don't know what stands now for her, what is her status. So if everything is fine, if I do not find any problem, and having had a history of her having one normal child and a spontaneous conception history, I can definitely offer her the second chance, the second child with IUI, if everything turns out to be normal after the counseling and the basic investigations.
Thank you, ma'am. Tomar, madam, how would you counsel this lady? What is her chance of having an abnormal child at the age of 38? Because
Yes,
that is
Pratik.
also a very real concern at this age.
Yeah, Pratik, I have to tell to the first patient, you can try either spontaneously or with the IUI, but you should know the complication of abnormal baby. You should know the complication of pregnancy, what can be the chances. So everything for the baby point, from the pregnancy point, I have to counsel first. Still she is willing, then definitely I would like to do all the baseline investigation on day 2 and X-ray, HSG and follicular study. But counseling part is important. They should not think of is as good as the in 31 year what she had the normal child and normal pregnancy she can have this time also. So about the baby, what Down syndrome can be there, what abnormal baby can be there with the multiple complication, and during pregnancy also she can have the problem. Now for the premature delivery, for the miscarriage, for the stillbirth, for the pregnancy with diabetes, everything we have to counsel. If she is still willing,
PIH.
definitely we will proceed for that. And we have to know in 38 years what the AMH is really important in this age group. So if she is willing, then we have to check on the day 2 all the hormonal level, and accordingly then we have to give the stimulation, and then we have to proceed. And simultaneously we have to check the husband sperms also, because she is 38, definitely husband must be somewhere 40. So all the investigation, if things are normal after doing counseling, still she want to have the child, then definitely I will offer her.
Thank you, ma'am. Dr. Rima has raised her hand. Yes, Dr. Rima.
Yeah. So the points that I will want to include in her counseling would be female fertility decreases with age, which and risk of spontaneous abortions, they increase with age. She's not exactly beyond 40, so I will just keep my discussions moderate. At this age, mostly what happens is the chromosomal meiotic non-disjunctions are more common, and that is why the genetic errors and the miscarriages are more once they conceive. Ovarian reserve, I would want to introduce that concept that ovarian reserve might be decreased at this point of time in her age. However, decreased ovarian reserve does not translate into decreased fertility also. So I will just tell her that your time now, what depending upon your ovarian reserve, that you must plan. You should not keep waiting for spontaneous, at this point of time, you just cannot. You may need some assistance sooner than later. And IUCD, after IUCD, I am going to basically check for, of course, ovarian reserve is one thing. Then tubal status would be another thing that I would want to check. And TVS definitely will give me a lot of answers. And that is it.
I think we've covered a lot of important points here. One is age-related fertility decline. Secondly, post-IUCD, sometimes the tubes can get blocked. And thirdly, of course, the incidence of aneuploidies and chromosomal issues, which are much more common at this age. Milind Shaskar, your expert views on this matter.
Yeah, good. Again, it was a wonderful discussion, but again, two, three things we need to actually consider. There are n number of studies which say that if the woman's age is more than 35 years of age, chances of getting aneuploidies is more common. But if the patient is second para, the chances are not that high. So one need to actually tell about this fact as well, because she had first daughter who conceived spontaneously, had uneventful antenatal period and delivery. So we need to tell her, yes, your age definitely warrants for more investigative approach when it comes to the aneuploidy detection. But as you have already got first child, the chances of getting aneuploidy in the second child are not as high as it was in primary, more than 35 years of age. Second thing about the AMH, yes. Again, we need to remind a very good point what you told, that not necessarily the fertility potential differ, because again the laboratory. So that's why what I do, I always correlate my AMH with my antral follicular count, and that gives me wonderful actually the explanation what is going to happen in this particular case. But it is absolutely her choice to get the second baby, so we can allow her second pregnancy if she wants. But we'll have to tell all these facts and files clearly, and we can go ahead. Yeah. About the IUI in this particular case, I think as she has spontaneous conception in the first Iui cycle, we can remove the IUCD and we can allow her the pregnancy. Most probably she will conceive on her own, supposedly time or intercourse. If it doesn't happen, so in 2 cycles, we'll have to immediately go for a little more rapid fire sort of investigation approach, because the age is now keeping limits on us. Her age is already 38 years.
Thank you, sir, and thank you all the panelists for your expert inputs. So we've covered all the important points here, and I think we need to. Yes, Dr. Amarika, you wanted to ask
One
something?
thing, like maybe it is a silly thing. I would like to tell them also, like, no infertility treatment could guarantee a boy or a girl, because they have already bought one girl child. Maybe like this is a one valid thing which has to be done. So,
I'm sorry, I didn't quite catch that. The audio was not so clear.
I would like to tell them that no infertility treatment can guarantee them a boy child or a girl child,
Obviously,
like
yes.
sexy
Yeah,
child.
yeah.
That is a caveat for all treatment.
Because I've seen a
You
lot
cannot
number of
guarantee
patients
any
coming
male
after
child.
so many years.
No, but sir
Very
has put in
practical
a
concept.
slide. Dr. Pratik has put in his slide that her cause of concern is that the first baby wants another company, not the second
Yeah.
male child.
Yeah.
Because the child is lonely. It's not because they want
Yeah.
a male child, but that's a very good
And
point. Thank you, Dr. Anurekha. Practically, we always need to address that issue with most couples. We don't discuss it often on a public forum, but that's a question which all of us get asked at least once or twice every single day in our clinical practice. Ladka hoga ki ladki hogi. And we have to be honest and tell them that it's not in our hands and it's not possible for us
Yeah,
to
and
or
not
them
only that, they Google it and they say that the multi-layer density gradient, suppose we can have the Y chromosomes which come up, and we'll have to tell them no, it's not.
Yes.
We always condemn as any organization these particular things. Yeah.
Obviously, it's not possible to do any of that. So we've talked about age-related fertility decline a little bit, but more importantly here I wanted to focus on the issue of aneuploidy, specifically trisomy 21, which can be significantly higher after the patient has crossed the age of 35. And we would be failing in our duty to our patients if we focus only on fertility treatment, only on IUI, and we did not talk about these important issues. We need to make them aware. And if somebody is from a good class or a good socioeconomic background, sometimes they would defer that decision and they would say, okay, one is enough. We don't need another child. That's all right. We are quite happy. We don't want to take this risk of having an abnormal baby and then go through that entire gamut of testing. That's their informed choice and that they have to be free to
In
make.
fact,
I
sir,
wanted to
yes,
ask, go ahead.
I feel that in fact you should also tell them that in the antenatal period they might have options of NIPT and they do need to
Exactly.
keep checking. So that is also an advice in the counseling only part. You have to tell them that these are the options that they need to do.
Correct.
That is
And
very
that is why I
important.
was waiting till this slide came up to ask.
Yes.
We talk about NIPT in public discussions and amongst ourselves, but how many of us actually advise it to our patients? How many of us have it
No.
available where we practice? Dr. Rima?
Combined test we are doing routinely for everyone, and only once there is some risk, high risk assessment, then we advise them NIPS because it is an expensive test.
Dr. Rekha, is it available in Bangalore? I'm sure it is.
Yeah,
But do
yeah,
you advise
yeah,
it to
yeah.
your
Very much, yes. Very much, yes. But as somebody mentioned, I don't advise it to all the patients. First of all, in the counseling, definitely this will be added because the
Yes.
patients otherwise also will ask, like, yeah, agreed that you're saying that chances of aneuploidy or whatever chromosomal abnormality is more, but do I have any solution for this? So we have to
Yes.
add this answer, like, in case it comes to that point, I have to do. But otherwise, it is not done from my side in all the cases. I go for the combination of age plus nuchal translucency plus nasal bone plus double marker. Suppose it is indicated, later I add NIPT, but I also give them an advice about the invasive method also.
All right. Dr. Anurekha, you are from Salem. Is this
Yes.
test available where you practice and how
No,
expensive?
sir, we used to send the samples to Chennai, sir, for some patients,
Okay,
like
okay.
ma'am said.
So you have to send it to Chennai and you get reliable reports. And what is the turnaround time?
As of now, I've not seen any conclusive report of NIPT, sir. It's always like inconclusive thing.
Okay.
Really?
And it turns out to be quite expensive also, probably. Since you are sending it to a different place, transportation,
But
turnaround.
instead, we are doing amniocentesis, and that also sample goes to either Coimbatore or Chennai. So we used to give the option to the patients, and if they're willing to wait for NIPT results and then go for a further thing, so we used to give the options.
Okay, so we probably will see this test becoming more ubiquitous in the near future, and probably it may change the entire paradigm of screening. But until then, the standard approach with dual and total markers still applies. We'll do one last case.
One more actually
Yes, sir.
addition to that, Pratik. Yes.
Yes, sir.
This is a very valid point which you had put in about this NIPT. See what happened, one of the platform I was attending, And someone said from the Gujarat that it's so easily available and cheap there. So they directly go for NIPT instead of going for the double marker. But I don't think so that is the correct approach, because we have seen that entire era, like, we used to send the sample to Hong Kong long actually back, and then they used to have a problem with the DNA retrieval. The reports used to come back saying that there's no adequate DNA retrieval. But now the technology has improved a lot. But we have to have our own guidelines, how actually we are going to advise them. There are also another extremes, like some people, even they don't know about it. So what they do, as soon as the double marker is actually the screen is positive, they say now we need to go for the invasive testing. And then the patients, they come to us, they ask us, doctor, what I should do. So we'll have to be very careful in that case. We'll have to tell them that no, there is one more actually ladder where you can definitely think about the NIPT, which will definitely rule out the aneuploidy. But yes, suppose again there is positive report comes in NIPT, we'll have to confirm it with the amniocentesis. So these 2 points, suppose we do good way in our counseling, the patient, they accept our counseling and go ahead on that particular part.
Thank you so much for those excellent inputs. We'll do one last case and we'll close this discussion. Yes, Dr. Rima.
जब NIPT directly बोलते हैं, so NIPT is a limited test. It is only there is
Screening.
so much that can.
Yes.
It is
It's only three.
Yeah.
3 chromosomes. Yeah.
It's a fish test that is not good. So it can actually not be directly doing it, not be very good.
So let's do one last case before we call it a day. This is a lady from a good class of society, and she initially wanted to have just one child, but that child has passed away because of an accident. This lady is now 39 years old. She wants to try for a child, but her android follicle count is quite poor and EMH is also low. Dr. Kumar, madam, she has come to you. You don't have a specialist IVF practice. Your view is going to be different from somebody who practices exclusively IVF. So I want you to tackle this case to start with. What would you like to offer her? Should it be IUI? Should it be IVF? Should it straight away be donor egg? What options are?
First, Pratik, I am going to counsel her because of the age. She is having the low AMH. So we can try with the medicine like we used to give for COI DHA and testosterone, and just see how her follicle is going to grow. Whatever, whether it's even the 3 follicle or in the next cycle, whether she's getting the better, even we can add the gonadotrophin. Suppose in second cycle she is not getting, and we will try our best. She should have her own follicles, so we can, if suppose tubes are patent, then we can offer the IUI. Suppose she is not responding to COI DHA also in 2 months, and even the testosterone we are giving, even the gonadotrophin we are giving, then lastly we have to counsel for the donor. If she is having 3 enteral follicle, we can advise her own also for the IVF, or that is also not going to work out. The third option is we have to ask for the donor oocyte also. So in 39 years, because she needs child, so we have to give 1, 2, 3 option. We will try with the tablet, with the gel, what we are getting nowadays, with the gonadotrophin. If it is going to work out, that's one thing. If it is not going to work out, then definitely we will try whatever follicles you are having the IVF. Even that is not going to fail, then third option is the donor oocyte. So now we will keep the thing on the patient, what she is planning to and how we can proceed. So 1, 2, 3, all options we have to keep open for her.
Thank you. So Dr. Anurekha, Dr. Sushma Kumar wants to try some androgens like DHEA or testosterone. In your clinical practice, how effective are these agents? Do they practically give any results, or we are just administering them for the sake of just keeping the patient happy?
So like for IUI, I don't prefer to use it, sir, because again it is going to be of economical waste. That is what I think. If the patient is going to plan for an ERT, the preparatory phase of testosterone patches or even like DHEA, as ma'am said, 90 milligram per day can be tried, and that should be at least some 2 to 3 months before the planned ERT. For IUI, I don't prefer to use it. And for this patient, this couple, if they want to go only for IUI, I don't go for all these things. I'll just go on with the gonadotropin ovulation stimulation with the IUI. That's all.
Okay, so probably this patient is a poor choice for IUI. So, as an corollary, I would like to ask the panel, what are the cases where you don't want to waste time with IUI and
Sir,
proceed directly with ART?
so she is not a case of IUI. She's a
IUI.
media
Yes.
manager. So I
Correct.
would first tell
Just
her
met with
ki,
an unfortunate.
yes, she will need an IVF directly and maybe pooling also. And
Mm,
testosterone is
Yes.
a short acting drug. So in fact, by the time I'm preparing her with rest of the investigations, the patch is a short acting. So in fact, I had spoken to Dr. Daniel. He's a professor in Israel. He said you can give a combination because DHEA takes a longer time to act. So you can work on a combination of DHEA and testosterone together. And you can work on that till the time she's been prepared for an IVF cycle. And because I said you can work on a pooling if she's keen on having her own genetic child, and then you can pool. And in fact, she's also a candidate for PGTA because her age is
Yes.
39, and she should be advised for all this in the counseling part. And then she should be given a blast transfer with a PGTA, and then if she's keen, as I said, on a self transfer and her own genetic child, and then gone ahead with
So,
the
if I
transfer.
can translate everything that you said into simple English for the sake of our audience who don't practice IVF, this
yeah.
patient is a poor choice for IUI.
Yes.
IUI may bring limited success in this particular patient, and at her age, she needs to have a take-home baby ASAP. She can't spend 1 year,
Yes.
2 years in that entire step ladder fashion of 3 or 6 cycles of IUI and then go to IVF and so on and so forth. So,
Yes.
long story short, you can administer DHEA and testosterone. They may bring limited success. Practically, they may not be of much clinical benefit until you give them for at least 3 to 6 cycles. That's the bare minimum that you need to do. Often, patients are not patient enough to wait for that long. And therefore, you need to prepare her simultaneously. She's a good case for IVF. This is not a case where you should try IUI and waste time. Dr. Rekha, I wanted to ask you any practical experience with transdermal testosterone. It's now more commonly and widely available, I think. So, have you used it in your clinical practice, being in
I
Bangalore?
have used, but I have used in very less number of patients. That too of late I've been using, but I'm more comfortable with DHEA because I felt that many of my patients got a positive result with DHEA.
Okay. So, DHA
And
is
I
still in
use it
certain
as
populations
in the
okay.
previous cycle I use for about 20 days, and I stop around say day 5 of the stimulation, day 3 to day 5 of the stimulation cycle. I stop it. So I use it around 15 days, the testosterone gel. But I use basically the DHEA.
All right. Can we have Dr. Milincha sir's expert on this,
Yes,
please?
yeah, yeah. We definitely give a trial of giving DHEA, but when we choose actually for IVF, the both choices, her own actually oocytes or the donor oocytes. But if we choose her actually own oocytes, we always and always think about this IVF embryo screening. And now you know that even NICS is available. In fact, we are doing one webinar on coming Saturday. I'm requesting you all to please join for that. So we can definitely go something little beyond PG in PGS, where we can definitely think of the NICS, which is available nowadays, non-invasive embryo screening, and
Yes.
they can get benefited with that. We'll have to tell all those facts to them very clearly, and we can subject them for accordingly for ART.
So multiple cycles of counseling are required before these patients will finally come up for treatment. We had a very nice, engaging discussion with all of our experts across the country on multiple different clinical scenarios. We tried not to repeat too many things as far as possible. I hope we've been able to convey a lot of take-home messages and practice points for everybody. Anything that we have not covered so far, which you think is important, which the audience needs to know, please feel free to speak. You can raise your hand and you can communicate. We still have about 10 minutes left, and there are one or two audience questions. I'll just quickly go through them while you are speaking. We'll start with Dr. Rima.
So IUI, IUI is a good modality if one knows the correct patient selection. in which kind of patient you should do it, when not to do it is even more important, as you rightly said, and when to stop doing it is equally important. So it cannot be entirely overlooked because it does take care of a good chunk of patients, but there is only so much that an IUI can do. Like roughly when I counsel patients, I tell them around 8 to 10% in a spontaneous conception cycle. Around it, you can increase the chances to up to, probably 18 to 20% with IUI. And if you have to go higher up, IVF, it will increase probably to 50-60%. So I give them all the choices and tell them the pros and cons, and as I said, make them a partner in decision making. Otherwise, you covered all the points.
That's a very good point, that we don't decide for patients anymore. The era has changed. We need to give patients their options. We need to counsel them appropriately, age specific and condition specific success rates, and then let them make an informed choice. Dr. Anurekha, anything else you would like to add?
Sir, like before going for an IUA, like I would like to counsel the patient that they can have their own intercourse. Like I don't prefer or I don't advise an exact abstinence before an IUA. Usually what I do is like before giving the trigger, I would advise to have a natural sexual intercourse, and then after the day of IUI, I would like to advise them to have a natural intercourse. That is not on the day of IUI, but a day before and a day after. So that is what I advise, because what I think is even the concepts of double IUI and all is based on the same. That is, we cannot exactly predict the time of rupture of growth. So it will also naturally the sexual intercourse also has some other benefits. Yes, so that also sometimes works. And one more thing, what I advise is the routine documentation of rupture of the follicle. I don't do it routinely because only in a few patients we don't get rupture of follicle after some 36 hours or even like 48 hours. It is up to maybe around 1% of the patients whom I have seen. So I don't routinely document the follicular rupture. Instead, this is the practice which I follow. So trying to have a natural plus IUI effect. So that is why I don't do routinely documentation of follicular rupture.
Okay. So some people do like to document follicular rupture and they call the patient back after 12 or 24 hours. Others may not want to, because they fear that sometimes the probe cover, the jelly which we use, again, we have to expand and so on. Dr. Tomar, madam, any words of wisdom from you after so many decades of practice? I'm sure you have some important practice points for you.
After doing so much of practice, still we are learning what from the other my colleagues also, their opinion, what their ideas. So every day we are learning some new thing. And I would like to thanks to Pratik. Almost after 1.5 years after COVID, this is after 1.5 years we are just meeting on this scenario because before he used to arrange so many of CME in Kalyan, so we always used to enjoy. But definitely with so nice topic, I would always request to have the more CME. Even on the Zoom, we are happy, but at least we can have the opinion of other our colleagues also, what they are doing in different cities, what their opinion is. So we have covered all the IUI and basic infertility. We are not going deep on the IVF, but definitely I will request to Pratik from all of our side, we have to have more this type of meetings, Zoom meetings, so we can have better discussion. Thanks.
Sure, definitely. Thank you so much. Dr. Rekha, ma'am, any practice points you would like to convey?
Yeah, one is always you involve the couple and if possible mother-in-law in the counseling part, because they have lot of decision makers they are the decision makers, especially the finance part. Don't go to the checkup and those kind of things. It's my practical word of wisdom, I can say. And second thing is like the lifestyle modification, most of the times we forget. part, especially the male partner, like the smoking part and exercise part or the job part, we forget to counsel them. That's the second thing. The third thing, coming to our aspects, is I start the progesterone not immediately after the IUI. I tell them to start after 24 hours of gap. Then I start whatever kind of progesterone is up to the practitioner, but I start the progesterone after 24 hours. The fourth most important thing is we should sensitize our fellow gynecologists, obstetricians, or even the GPs to categorize the patient and to refer the patient early to the proper destination point, so that the patient's golden hours are not, golden period is not wasted in doing all different kinds of beating around the bush. That's all I would like to say. And thank you, Dr. Prati, for the opportunity.
Not at all. Most welcome. And I think very important clinical points that we need to also take the other family members into consideration, especially if they are members. And we need to also counsel people who are referring patients to us that there are certain categories where they need to refer patients early and not waste time with clomiphene and letrozole, oral ovulation induction movements.
Like your last patient, like your last slide, they put the patient on CC and CC for months together.
Months together, absolutely right.
Yeah.
Dr. Shekhar ma'am, any closing remarks?
Yeah. So what I would like to say is that triggering is very important. So which agent when to trigger is also very important. Like clomiphene and oral ovulogens, the trigger limit is when the follicle size is somewhere around 21, 22. And when you are using gonadotropins, the trigger is somewhere around 19, 20. So that is also something which we need to consider. And even Doppler studies have come into the picture, come into the role. So first we used to not consider that. Now recently that also plays a very important role. Sometimes we don't understand when to trigger. So the blood flow also plays a very important role. So where we do our own scans, we can put the color Doppler and see. That gives us a guidance when to trigger. So I think those are important points. And like how Madam said, when to refer and when to stop is a very important point. That is something which I would like to emphasize. Thank you, sir.
Perifollicular vascularity, subendometrial blood flow are concepts which we as OBGYNs are just learning now. It's always helpful to have a good radiologist colleague who can help you out in those difficult cases where you are not getting success and maybe you need to add something different to the mix to give results to your patient. Dr. Milind Shah sir, our expert on the panel, for closing remarks.
Yeah, before that, I think Rima wants to say something. She was raising her hand. Yes, Rima.
Yes, Dr. Rima.
Yes,
So
Rima.
Sheetal was talking about triggers. So even I agree with her that some technical aspects, when we are doing an IUI, थोड़ी इज्जत देनी पड़ेगी IUI को भी. Like a lot of times in the lab, since the time I have started paying attention to when the sample was given, when it was picked up by the reception person to the endology lab, to the time of insemination, a lot has changed in my scenario. So these are little
90 minutes. That 90 minutes is the crucial time. नहीं तो पहले होता था दूसरे जगह पे sample pick होता है. That 90 minutes is that crucial time.
Yes.
And even
ma'am also pointed out कि एक जगह दे रहे हैं दूसरी जगह वो these points यही हैं जो main है. बाकी सब
If you have a well-planned center, then there is only one wall which divides the andrology lab and the collection room. There is a ledge where the patient male partner goes out and the sample is immediately.
And even I think we have a lot of. So one more thing, even we have a lot of gynacs who are listening. Even when difficult IUIs that you are doing, if you can do these IUIs under ultrasound guidance, I think it makes it so much more smoother and easier. You should try doing that.
Yeah. Thank you. Yes. It was really a wonderful discussion, Pratik, and I must congratulate you for organizing such a nice discussion. And I'm so happy to have all those inputs from Dr. Rekha, Dr. Sushma, Dr. Anu Rekha, Rima, and Sheetal. We are missing Kalyani and Deepak actually in between. Very, very, very well covered all those aspects. Only two actually things which we can add upon. That is, one is the semen preparation technique. Because again, this is a recent experience, we keep on having the embryologists, sometimes they change, and she brought a sample and she said, yes, now the semen is ready and I have done this SMEMUP technique and there was no hard pellet. And I was just wondering what must have happened. So I was telling her, tell me once again what has happened. She said, I'll to mix with that, the whatever bottom part, and we are going to utilize the same. I said, no, swim up we do in different way. So she said, see, this kit is different. And then I realized we need to have a little address to that also. We'll have to go ourselves in between, not routine, but randomly we need to check on the semen preparation techniques as well, whether the things, go wrong if they're actually in the laboratory. And yes, the point which was added about the IUI technique also, which is again very, very important, because all said and done, little insult in the endometrium, a single drop in the endometrial cavity changes the pH, and definitely your results will come down. So we'll have to be very careful and very, very proper in doing the IUI properly to avoid the disruption of the endometrium. And yes, ultrasound guidance, or sometimes managing suppose the cervix is very much stenosed, doing sometimes even mock actually the entry to find out where exactly the canal is. Or we draw it actually on case paper, the point of entry at 3 o'clock or 9 o'clock, and we slowly go and we do it and we get the wonderful results. So all those points are very, very important when it comes to the practicality of the IUI. And I must congratulate all of you, and we must say thanks to Nandita and Arun also for this wonderful opportunity, because that made us to speak so much and learn from each other. Everyone, though we practice for 1 year or 100 years, we are always students. We keep on learning something new from each other, and we enjoy it. Pratik, it was a really wonderful and awesome actual discussion. Thank you very much.
Thank you so much, sir.
500 viewers who are logged in, more than 500 attendees. There are just 2 or 3 relevant questions. I quickly take them before we present the formal vote of thanks. The first one is from Dr. Munisha from Uttar Pradesh, and she is asking when to use HMG for induction. Anybody would like to take that?
What's the
When to use HMG for induction?
Whenever your oral agents.
So I would say that you use
second line of treatment
in all patients for best results and for quick results to shorten the time to pregnancy. There are 2 agents which will help you achieve success in Iui cycles quickly. One is gonadotropins and the other is antioxidants for the male partner. We shouldn't forget the male partner. And the second question is injection FSH or HMG, which is better for ovulation. This is from Dr. Amitav Sen from West Bengal. I think we've covered this earlier, that both of them are equally good. HMG is a little cheaper sometimes. So to reduce the cost per cycle, sometimes we prefer to use HMG. Yes, ma'am?
So in fact, there has been a study which was conducted, and in fact, it said that HMG in fact reduces the chances of OHSS. So if you feel that there is going to be OHSS, you should use HMG. So that is what is the study.
So by and large, for most IUI cycles, we would be
prefer an
using HMG, and that would not make much of a difference
in the results.
As long as the pool change. And one last question. This is from Dr. Sethi from Dehradun. Dr. Rima, anybody known to you? And he or she is asking how long can we keep washed sperm sample before IUI? We talked about this just a couple of minutes back.
Yes, ma'am. So timing is very, very important. As soon as the sample is given, it should actually start, and the processing should start. And they say within the first 30 minutes, the washing should be done, and within the 90 minutes, it should have been, the insemination should be over. So this timing is very important, and anyone wants.
Perfect. So approximately 90 minutes. I think this was mentioned a little while earlier, and that is the upper limit. And obviously, during those 90 minutes, it has to be maintained at 37 degrees. We often take that for granted. But sometimes the semen sample has to be transported from one place to another place, and we lose that much time. So that also has to be taken into account. So fantastic discussion. Thank you, everybody, my esteemed panelists and our expert. I'd just like to present the official vote of thanks at the end. My gratitude to the AMOG's office bearers, our esteemed President, Dr. Nandita Palshekar, Secretary, Dr. Arun Nair, the ICOG office bearers, our Chairperson, Dr. Uday Thanawala, and Secretary of ICOG, Dr. Ashok Kumar. Thank you for the ICOG credit point.
Doctor,
to all of our, yes, ma'am.
Dr. Pratik, I've been interrupting you. Extremely sorry. Before you bring the curtain down, I would like to say that probably, I don't know, this is the first time it's come to my knowledge that 2 full hours of discussion practical discussion, that too on IUI, because most of the seminars it would be 2 talk or something like that, and last 40 minutes is only discussion on IUI or something like that. But this is the exclusively, the whole session is meant earmarked for IUI and practical, and so that's why probably you had 500 participants, because a very interesting topic. It's amalgamating topic for the general practitioners, the obstetricians, and the infertility specialists.
Thank you. This is the way we like to do things. Make it simple, make it practical, and keep it clinical. So thank you, Dr. Milind Shah, sir, Dr. Sushma Tomar from Ulhasnagar, Dr. Deepak Goenka from Assam. I think sir was busy in a cesarean and therefore could not join us. Dr. Rekha from Bangalore, thank you so much, ma'am. Dr. Kalyani, we presented apologies on her behalf. She is unwell and probably will join us in the next one. Dr. Sheetal from Mumbai, Dr. Anurekha from Salem in Tamil Nadu, and last but not least, Dr. Rima from Dehradun. Thank you so much, everyone, for a fantastic panel. I also need to thank our education partners for today, who are Acumentis Viviana, and let us not forget Science Integra, Subbu, Session, Fremont, all of you do wonderful work. Thank you for being our background. To the 500 plus audience who are logged in case you wish to download your certificate, just refresh the audience portal page and there will be a download button which usually gets activated after 3:30 p.m. only, and you will get your ICOG credit point certificate. So thank you all of you for joining us. Until the next time, take care, God bless, and stay safe. Bye for now.
Thank you, sir.
Thanks. Thanks, everyone.
Thank you. Thank you very much. Yeah.
Thank you, everyone. Bye bye.
Thank you.